Welcome everyone to today's webinar. I am Layla, the Community Engagement Coordinator with the Canadian Cancer Survivor Network. Today's webinar is entitled Who Does What in Canada's Healthcare System, presented by Ryan Clark. Ryan Clark is the president and founder of Advocacy Solutions, and he helps advocates synthesize advocacy campaigns, amplify campaign messaging, and engage and influence key decision makers through the development and implementation of impactful advocacy strategies. In today's webinar, Ryan will provide an overview of the structure of our healthcare system, give a review of Canada's Health Act, and provide everyone with a better understanding of the intersection between delivery and financing in healthcare. At the end of the presentation, he will be able to answer your questions. However, at any time during the webinar, please feel free to type questions into the question box on your panel. For those of you who have not attended an earlier webinar, the Canadian Cancer Survivor Network is an organization that works with cancer patients and survivors to learn about health system complexities, connect with others to plan action, and act to promote best care and healthier survivorship. If you'd like to learn more about CCSN, please visit our website at survivornet.ca. This webinar is being recorded and it will be available on YouTube. In addition, the slides will be available on SlideShare. Links to both will be sent to the email you provided. I will now turn things over to Ryan. Welcome.
Thank you, Layla, and welcome everybody to this webinar. So here's the agenda for today. We'll talk about 5 common myths around Canada's healthcare systems. I'll go through some statistics with you, a quick refresher and government overview because of the importance of that in understanding both the governance and the coverage structure of our systems. As Layla said, we will cover the Canada Health Act, the various roles, as well as delivery versus financing, and then your questions. So Layla went through these outcomes with you, but I just wanted to let you know the rationale for why we wanted to offer this webinar is because if you are going to advocate to government about healthcare issues, you really need to have at least a basic understanding of our health systems in Canada. So this webinar is an introduction meant to provide you with that general overview. And I will emphasize it is really just an introduction. We're going to touch on a number of different things today, but just in the interest of time, we're not going to go too deep on anything in particular. I thought it would be interesting to start with 5 myths or realities about our healthcare systems. These 5 slides I'm going to share with you now were initially designed for an American audience, but I know from my own experience that many Canadians also believe much of what I'll walk you through as well. So let's start with one of the most obvious ones. The first myth, people often refer to the Canadian healthcare system in the singular. We do not have one healthcare system. And as you'll see from sort of here on in, I'm going to use the word systems rather than system. And that is because we have a number of healthcare systems. Each province and territory has its own healthcare insurance plan. And then the federal government is also responsible for delivering healthcare services to a very defined and narrow group of people in this country. We'll chat more about that in a moment. But again, we do not have one system in this country. We have several healthcare systems in this country. Secondly, the Canadian healthcare system is a single payer system. Canada does not have a true single payer system. There are true single payer systems in the world. We're not one of them, but the perception is that we are. Rather, a significant portion of Canadian healthcare comes from both public and private financing. We'll go into this in more detail. So as it says there, for example, most Canadians have to pay for eye and dental care out of pocket or through private insurance. The Canada Health Act does not cover prescription drugs, and it's estimated, as it says, about 60% of prescription medications are paid for privately in this country. So the second myth about having a single payer system, again, is not true in its literal interpretation. Third myth, healthcare services are provided equally across the country. Absolutely not. The Canada Health Act, which is the only piece of legislation that has components to it that ensure things like universality and accessibility across the country, are only cover portions of what's delivered in the context of healthcare. The details of how each system operates, including what is covered by insurance and how it's covered, as you all know, is determined provincially and territorially. There are elements of equality, but they're actually quite narrow when you dig into them. This is not, healthcare services are not broadly equal across the country. Fourth myth, the Canadian healthcare system is socialized medicine, where physicians are government employees. You all know that that's not true, but again, there are people who do think that it is true. It's a publicly funded healthcare system, but physicians in particular are self-employed, not government employees. There are some pockets of physicians that are, but generally speaking, no, not within our system. They earn money by billing their provincial and territorial governments for the services they provide, and they have a measure of independence around hours worked and location, and they're responsible for essentially running their business. There are models in Canada in various provinces that I'll say have a role to play in how physicians do some of these things. So not every physician has complete latitude or freedom in terms of hours worked, location, all the rest of it. But by and large, that's still generally the case for most physicians in this country. And so it cannot be defined in any way as what one would refer to as socialized medicine. And finally, there are long wait times for care, which compromise access to care. Again, the reality is, and this holds true, perhaps withstanding the pandemic, but certainly before the pandemic, there are no wait times for urgent or primary care in Canada. I don't mean you can necessarily get it the same day, but in the general definition of what a wait time is in healthcare, there are no wait times in general for urgent or primary care. There are usually reasonable wait times for most specialist care, not all specialists, there are long wait lists. But where you get into the issue of much longer wait times is around elective surgery. And we do have long wait times for elective surgery in this country. We always have, and up until now, we certainly, that has been the case. And so that's the perception that often gets put out, is that we have these long wait times, but it's only around, typically around elective surgery. Again, though, always this caveat, wait times, like everything else, can certainly vary across the country. Now, let's turn to some statistics, to level set the discussions. So we'll start international, and then we'll kind of go down from there. So per capita healthcare expenditure in selected countries in 2018, you can see Canada is high on the list. In fact, it's number 4 in the world in terms of per capita health expenditures across the board. You can see that the United States is by far the leading country, almost 40% more than Germany, which is number 2. But we do spend a significant amount relative to other countries on healthcare expenditures per capita in Canada. Note that these are US dollars, because you're going to see a comparison in a moment. You're going to see me flip over to Canadian dollars on the next slide and moving forward. So the top stat on the top left-hand corner, that's for 2019 in Canadian dollars. So total healthcare spend in Canada, all of it, everything, 2.64 billion. It was actually estimated to be, the final numbers for 2019 aren't in yet, or they might be. That might be a solid number, but it's 264 billion. So you're talking a huge amount of money on healthcare and growing, and that translates into just over $7,000 in 2019 per Canadian citizen spent on healthcare. And for the bottom stat, the public and private split in healthcare costs is typically around 70-30 in Canada. So what that circle graph on the bottom tells you that in general and relatively consistently, with some leeway back and forth, but relatively speaking, 70% of all healthcare expenditures, these are dollars, percentage of dollars spent, are spent through public funding, and 30% approximately are spent through private coverage, so including out-of-pocket, private insurance, and that kind of thing, but essentially not tax dollars. So where did each of us spend that $7,068 for our healthcare in 2019? Well, this is the graph that illustrates that, and if you add up those numbers, it adds up to almost exactly $7,068, slight rounding error, along with the percentages. So the vast majority of money was spent in hospitals, consistently number one in terms of single healthcare expenditure. Secondly, you have physician salaries. Then you've got prescribed medications coming in at number three. Note, if you combine prescribed and non-prescribed medications, that would actually be the second largest one. But for the purposes of this graphic from CIHI, the Canadian Institute for Health Information, they separate out prescription drugs and non-prescription drugs. Then you see some other large components. Again, this is total healthcare spend. You see some other large components, and then you see some relatively narrow components as well for 2019. I thought I'd throw this slide in really just as an aside, but you may want to just take a quick look at COVID-19 expenditures by governments and how they were allocated for much of 2020. So this is a snapshot of spending on, again, COVID-19 related spending between March and October of this year. And so most of it spent, the single largest one spent on PPE, personal protective equipment. Then you've got other funds unallocated. I'm not exactly sure what that means. But then you've got screening, compensation to health workers. You'll recall that as part of the ongoing part of the pandemic in terms of public expenditures and vulnerable populations. Medical research and vaccines is only 4% of what was spent by all of the governments during the first part of the pandemic. And finally, on this slide, the provincial territorial breakdown of that $7,068, versions of which many of you may have seen over the years. This is a very, very popular slide. It gets updated every year by CIHI. And so just a few things to note. Number one, in Quebec, notice the large increase in healthcare spending year over year from 2018 to 2019. In Alberta, notice the very small increase in health spending, less than 0.5% in terms of year over year. And then you can see the raw numbers, the actual raw numbers that are being spent to get us to that Canadian average per capita of 7,068, much more expended per capita in the territories than in the provinces. The provinces are relatively clustered. It looks like a swing of about $1,000 between provinces, but those are the most recent numbers that we have. Now, if you were with us for our last webinar last month, you'll recall the next few slides on the structure of government in Canada. I'm going to quickly review some of this content again, just because it's so fundamental to understanding why we have the healthcare systems we have and how they operate. So these first few slides, I'm not going to spend a lot of time on. Again, you've seen them if you were with us last time. This is a federal state that we live in Canada, parliamentary democracy, constitutional monarchy. We have three levels of government, federal, provincial, and territorial. Each level of government has its own arrangement as to how it operates. And remember, the federal and the provincial governments are the only ones that are enshrined in the constitutions. Municipal and local governments are a creation, an artificial creation, but nevertheless, pursuant to the Constitution, a creation of the provinces. Three branches of government: federal. We have the monarch who sits atop the branches: legislative branch, executive branch, judicial branch. I'm not going to go through this again in any detail. This is just a quick overview to remind you. And then the three branches of government at the provincial level. Again, the monarch sits atop. Same thing: legislative, executive, and the judicial branch. Okay. Our Constitution. I am going to go through this in a little bit more detail again, and then link it up to healthcare, which we didn't do in the previous webinar. So there are three main parts to the written component of our Constitution. There's the Constitution Act of 1982, there's the Charter of Rights and Freedoms, and then there is the amending formula. When they chose to form a federal form of government in Canada, the Fathers of Confederation assigned particular responsibilities to the federal and provincial governments. Remember, only two levels of government are enshrined in the Constitution, federal and provincial. And those are outlined in sections 91 to section 95 of the Constitution Act of 1867. The Constitution Act of 1982 is just an updated version of the Constitution Act of 1867. Now, before we leave this slide, a couple things I want to sort of mention here, just to kind of get it out of the way. You do not have, none of us have, a right to healthcare in Canada pursuant to the Charter. We do not have a right to healthcare in Canada pursuant to the Charter of Rights and Freedoms, but rather we are, as Canadians, entitled to certain healthcare services under certain circumstances pursuant to various pieces of legislation, regulations, policies. Those entitlements can be changed anytime by governments by simply passing new laws. So it's really important to understand where healthcare sits relative to that. On the other hand, rights under the Charter cannot be changed without amending the Constitution, and that is extremely difficult to do. It's only happened 11 times since 1982, and all of those amendments were considered minor in nature, and I found an example of this. The Constitution was amended to allow for a fixed link bridge to replace ferry services to Prince Edward Island. I'm not exactly sure why we needed a constitutional amendment for that, but we did, and that's the kind of thing that we're talking about. There have been no major constitutional amendments since 1982, and nothing to do substantively with how healthcare is delivered in this country. So sections 91 to 95, as it says there, this division of powers is based on the idea of subsidiarity, meaning that the government level closest to the issue governs it. All powers emanate or are grounded in these sections of the Constitution, including healthcare. No government can do anything in this country, no federal government, no provincial government can do anything in this country in terms of exercising a power unless that power is grounded in the Constitution. And so, as I'll show you in a moment, where sort of from a healthcare perspective, where these powers kind of emanate from. Section 91. Section 91, as you remember from the last webinar, sets out the federal powers. There's only one direct reference related to healthcare as it pertains to the powers of the federal government, and it is extremely narrow in scope. It is section 91 sub 11, quarantine and the establishment of maintenance of marine hospitals. Now, that's not the only power the federal government has in healthcare, but it's the only explicit, or what we call direct power, that is set out in the actual Constitution. Provincially, there is only one direct power as well in the Constitution as it was drafted in 1867. It is section 92 sub 7, the establishment, maintenance, and management of hospitals, asylums, charities, and eleemosynary institutions in and for the province, other than marine hospitals. Remember, marine hospitals are the jurisdiction of the federal government. LMOS and area institutions are ones founded by charity. The word healthcare didn't exist in 1867. There's no reference to healthcare in the 1867 version of the Constitution, or the 1982 version for that matter. And so, again, the only direct power that the provinces have is here. However, unlike the federal power, which is very, very narrow in scope, this is not narrow in scope. It's actually quite broad, comparatively speaking, in scope under Section 92, sub 7. But it doesn't stop there. It isn't just the federal powers are found in 91.11 and the provincial powers in 92.7. The structure of healthcare in Canada also rests in part on what we call indirect sources of constitutional power. So there are other parts of Section 91 and Section 92 that give the governments enhanced power or influence, and it is both power and influence, over healthcare in Canada. So the provinces have exclusive jurisdiction for the direct delivery of most medical services through not just Section 92 sub 7, but also the powers over property and civil rights under sub 13, and matters of merely local or private nature under sub 16. The federal government has jurisdiction over not just those found in sub 11, those narrow ones in sub 11, but also drugs and food through the criminal law power clause, that's Section 91 sub 27. The reason that the federal government gets to approve medications in this country as opposed to the provinces is because the federal government has exclusive jurisdiction over criminal law or substantive criminal law. Financial contributions to the national Medicare system through the public debt and property clause and its general taxation powers. And then national health emergency potentially through the peace order and good government power that serves as the introductory part of Section 91. So again, I'm going through this with you in some detail to show you that there are some direct powers through the Constitution and some more indirect powers through the Constitution that have been subject over 150 years to interpretation that has all been done to create the systems that we have today. Because of what I just went through with you, that's why we have the systems we have today. So the overall structure. In general, healthcare in Canada is publicly funded but privately delivered. Publicly funded but privately delivered. So this means that the vast majority of healthcare services are free, meaning you're not asked to pay to pull out a credit card at the point of use, but that they're delivered by private providers, i.e. physicians. Both administration and service delivery are highly decentralized in our system, and the administration of those systems is a mix of public and private. And as all of you know, there are significant inequalities within the systems, not just geographically, but most notably amongst Indigenous populations and some vulnerable groups. And we'll explore much of this in the time we have remaining in the presentation. So we divide overall structure into governance and coverage. This is one way to describe it. I think this graphic is actually quite a good way to describe it. There are other ways to describe it, but I think that this one makes a lot of sense. So overlying all of this is the Canadian Constitution that we just went through. And you cannot lose sight of the fact that the Canadian Constitution sets the stage, sets the framework, and it all comes back to why do we have the systems we have? Because of the Canadian Constitution and the division of powers I just went through with you before a moment ago. So on the left, we have the federal government and the work that they do or the services they provide under the Federal Minister of Health. You've got Health Canada and then some other components. I'm going to talk about those in a moment. You've got the Canada Health Act in the middle, and the whole ability to use transfer payments in the context of monies going from the federal government to the provincial governments. We'll talk about that in a moment. And then you've got this collaborative approach. If you see the third box down in the middle, I will talk about that at the conclusion or a little further on in my presentation. I'll talk about that as well. Then on the right-hand side, of course, you've got the provincial and the territorial governments who are responsible for, in large part, the delivery of healthcare services. You've got medical associations, which I will talk about regulated health professions a little bit. Health professional unions, I'm not going to touch on that. And regional health authorities, I'm not going to get down to the level of regional healthcare delivery in this country, in part because it is constantly changing. It's very different by province. And it just, in the interest of time, I really don't have the ability to go into detail about that. But here's an overall schematic of the governance of our systems in Canada. Then we move to coverage, as in who gets what through what, when, and all the rest of it. And so this is, again, a graphic illustration of that, and it's divided into layers. Layer 1, purely public healthcare services, public meaning publicly funded healthcare services. Layer 2 is a mix of public and privately funded systems. And then layer 3 is almost all private funding. And it's important to say almost all because even in dental and vision care, there are some public components. So there are some elements of healthcare in Canada, I suppose, that are 100% private, but not I mean, there are individual services that are 100% private, but I don't know that there's any large component that is 100% private. Again, even dental and vision, which is largely private, still has a public component to it. And so that's why it says almost all private funding. So you can see the services that are listed there, of course, largely in layer 1, you've got hospitals, physicians, diagnostics. Layer 2, that's where medications come in, and a lot of home care, long-term care, and that kind of thing. And then layer 3, as we all know, that's where you have your dental and vision and other components. Funding in layer 1 is clear, that comes through public taxation. Funding in layer 2, also public taxation, but also through private insurance and out-of-pocket payments. Again, we all understand that. And then layer 3 is primarily public insurance or out-of-pocket. Administration, I won't go into a lot of detail, but again, it's decentralized and it varies to some extent, whether you're talking about layer 1, layer 2, or layer 3. And then delivery again is still largely private. So again, publicly funded, privately delivered. Sometimes it's a not-for-profit facility and sometimes it's a for-profit facility. It just depends. In layers 1 and 2, you have a mix. In layer 3, they are going to be, again, probably almost exclusively for-profit facilities. Again, the ones that actually deliver the health care. So the federal role, the actual role that the government plays, the federal government plays in healthcare. They assist in financing provincial and territorial healthcare services through fiscal transfers. Money is the federal government's big stick in the delivery of healthcare services. That's their big role to play in all of this. It's not delivery. Again, they have a very small role to play in direct delivery. It's about they have money, provinces need the money to deliver healthcare services as they're required to do under the Constitution. And so that's the big piece, or the big role that the federal government plays. However, they also set standards and principles upon which the transfers are contingent. They do deliver specific health care, as we said, and they provide and fund other health-related functions. So Health Canada, a little bit more detail. I know there's a tremendous amount on this slide. I'm not going to go through all of it, but it's a bit more detail from that governance graph I showed you a moment ago. Health Canada, as a federal institution, has as part of its health portfolio these 4 components here. amongst other components. This is not a finite list. The Canadian Food Inspection Agency is part of Health Canada, Canadian Institute for Health Research. Much of the statistics that or if not all of the statistics I should say, sorry, not all of them. Some of the statistics that I showed you today came from CIHI, which is something else, but it often feeds into and has a relationship with CIHR, Canadian Institutes of Health Research. PMPRB, which some of you are familiar with, the Patented Medicine Prices Review Board, gets into the issue of how drugs are priced in Canada, and the Public Health Agency of Canada as well, which of course we've heard so much about in the context of the pandemic, is a critical component of what falls under Health Canada's jurisdiction in this country. Now, let's turn our attention to one of the most misunderstood pieces of federal legislation I think ever enacted, and that is the Canada Health Act of 1984. The Canada Health Act does not entitle Canadians to healthcare services anywhere in the country, as I believe it is often interpreted. Rather, it is an insurance plan. That's all it is. The Canada Health Act is an insurance plan, but instead of being a private insurance plan, it's a public insurance plan. So it's Canada's federal health insurance legislation. It establishes the criteria and conditions related to what are called insured healthcare services. Not all healthcare services are insured. Insured healthcare services, so what we call the national standards, which the provinces and territory must meet in order to receive the full federal cash transfer contribution. Historically, insured services, the definition of an insured service, is largely restricted to care delivered in hospitals or by physicians. So, what we're talking about here is the federal government, back some 37 years ago, decided that the Constitution doesn't allow us to get into the business of direct delivery of care to Canadians. But we have other powers that we can utilize that we talked about. And one of those powers is the large power of the blanket power of taxation. And the provinces who are responsible for delivering healthcare need money to do it. So the Canada Health Act was enacted to set up the framework in which the provinces are required to do certain things if they're going to get money to deliver healthcare. And they need the money because they have a constitutional responsibility to deliver healthcare. So this is an indirect way for the federal government to get into the business of delivering healthcare without actually getting into the business and without violating the construct and the division of powers within the Constitution. And because it's been restricted to services delivered in hospitals or by physicians largely, you can see that many of the clinical interventions and professional services that are integral to our current healthcare system are not covered. Medications, not covered by the Canada Health Act. Home care, not covered by the Canada Health Act. Only those services that are largely delivered in a hospital or by physicians. The Act states that the primary objective of Canadian healthcare policy is to protect, promote, and restore the physical and mental well-being of residents of Canada and to facilitate reasonable access to health services without financial or other barriers, or those that are covered under the legislation. Remember, they're not all covered. Only some of them are covered. So to do so, they set up a list of criteria and conditions that the provinces and territories must follow to receive their transfer payments. And some of you may be familiar with these: public administration, comprehensiveness, universality, portability, and accessibility, which I'll cover off briefly in a moment. There's also a requirement, you may not know this, that the provinces ensure recognition of the federal payments and provide information to the federal government. This legislation requires the provinces to tell everybody that the federal government made these payments and that the federal government played an active role in indirectly providing healthcare to Canadians. Okay, these are the 5 components of the Canada Health Act. And again, this is where there, I think, is a lot of misunderstanding about what these components mean and how they actually operate. So if you're a province and you want all your money, then you have to comply with all of these things. So health insurance plans, your health insurance plan provincially must be administered and operated on a not-for-profit basis in the province or in the territory by a public authority. The health plans must cover all insured health services provided by hospitals, medical practitioners, or dentists. It says or dentists, by the way, that's optional kind of thing. And then the provinces are allowed but not required to insure additional services. Universality. All insured persons must be covered for insured health services provided by the plan on uniform terms and conditions. So what that means is, if you are an insured person, then you must be covered by the insured services that are under the Canada Health Act, those delivered in hospitals, those delivered by physicians largely, in a uniform way, in a uniform manner. Universality does not mean everybody gets everything across the country in the same way, or everybody gets everything. That's not what it means. Universality, I would argue it's a misuse of the term universality under the Canada Health Act. It does not truly mean universality, but that's the term they decided to use. Portability, if you move from one province to another, there can be minimum wait periods, but they're not to exceed 3 months. They can't be unreasonable sort of thing. Again, only for insured services. So if you move from one province to another and you're looking to get access to medications, that's not an insured service, so it's not 3 months. It could be 6 months, it could be a year. The provinces can decide on their own, not subject to the Canada Health Act. And finally, accessibility. The insurance plan must provide for reasonable access to insured services by insured persons on uniform terms, and then unprecluded, unimpeded, either directly or indirectly by charges. This is the one that means you can't have surcharges, you can't have fees, you can't have fees hidden to all of this under the Canada Health Act. If you want your money, if you're a province and you want your money, you can't be charging all of these extra fees to people. Okay, that's the federal role, that's the Canada Health Act. Just a few more slides. The provincial and territorial role is different. And so pursuant to the powers granted in the Constitution, the provinces and territories are responsible for the huge, vast majority of healthcare delivery services in this country. So they administer their health insurance plans. All of them are slightly different. Planning and funding and care in hospitals and other facilities, services provided by physicians and other healthcare professionals, particularly regulated healthcare professionals, which I'll touch on in a moment. Planning and implementation of health promotion and public health initiatives. You'll notice that there's a public health component at the federal level and there's a public health component at the provincial level. And indeed, the province has created a public health component at the municipal level or at the local level. And then negotiations of fee schedules with health professionals is another exclusive role of the provinces. Now, going back to that coverage table I showed you, let's talk about the delivery of healthcare services. Healthcare delivery means the manner in which medical services are organized, managed, and provided. Organized, managed, and provided. In large measure, healthcare is delivered through private providers. The healthcare industry is the second largest employer in Canada with over 2 million people, and you can divide these services into 3 types: public, mixed, and private. So public is a hospital. You'll recall this from that table I showed you. Mixed is prescription medications, for example, and private is dental and vision, although again, even in the private sphere, there are often public components. In Ontario, for example, there are publicly funded programs for certain groups of seniors who need both dental and vision care services. The province will pay for certain groups of seniors for dental care and vision care. Key players in delivery, you saw these numbers before. They are the hospitals, physician services, and prescription drugs. Other key players in delivery include nurses, pharmacists, and other regulated healthcare professionals, which I'll touch on in the next slide. You then go down to unregulated healthcare professionals like personal care workers. And then finally, you've got things like diagnostics and devices and that kind of thing. I'm talking about key players. There are many, many other players in our system. I'm not touching on any of them, but these are sort of the, as it says, key ones. So in this country, in every province and territory, we have what are called regulated health professions. And regulated is kind of a misnomer. They're not regulated by the provinces. They are self-regulated pursuant to provincial legislation. So what do I mean by that? Physicians self-regulate in Ontario and everywhere else. There's legislation in every province and territory that empowers physicians to self-regulate themselves rather than the state actually directly regulating them. They set up a body, a college, that self-regulates the profession. All of these professions, this is a list, by the way, of the 26 in Ontario, are all regulated through the mechanism of self-regulation. And note that not all provinces or territories regulate the same health professions in the same manner. There are some differences, particularly in how they're governed or regulated, I should say, between provinces and territories. That was delivery. Now financing, money. Healthcare financing refers to how medical services are paid for. In large measure, healthcare is financed through public funds. Remember the 70-30 split, but that is evolving to some extent. And financing comes from three primary sources: public, private, and out of pocket. You'll recall from that graphic. Public, as noted before, approximately 70% of all healthcare expenditures are made by the provinces, the territories, and some federal. Private. Private insurance through your place of employment or that you purchase yourself is often used to supplement secondary or additional care. And then out of pocket is increasingly being used by those with the means to purchase additional care. Most people don't have the means to do it, but there is a growing segment of services that are financed through out of pocket for those people who do have the ability to pay for those services. And finally, this is my last slide. Again, referring back to that governance graph, it notes some examples of national healthcare bodies or roles in which the federal, provincial, and territorial governments share responsibility and funding, share both responsibility and funding. One of the obvious ones that I think we all know about is Canadian Agency for Drugs and Technologies in Health, CADTH. Another one is CIHI. That's the one that I was referring to earlier, that provided all of those statistics that I shared with you internationally, nationally, and at the provincial level. And then also Canada Health Infoway, which has been around for some time, which jointly invests with every province and territory to accelerate the development and adoption of health information in this country. And that is all I wanted to cover off today. Layla?
Thanks, Ryan. So we still have some time for questions. I have a few here, but if anybody else still has questions that they'd like to ask, you still have time to submit them. So the first question is, does private funding include funding from charities?
Yes, it would have to. So because it's not run through public taxation. So if a charity directly provides funding for a healthcare service, it would be considered private. Things like GoFundMe campaigns or that kind of thing as well. That would be done through private as well. But yeah, I think so. I don't think that would compose any of the 70%.
Next question, in the context of COVID, what emergency health measures can the federal government put in place under the Peace, Order, and Good Governance Clause?
That's a good question. I don't know exactly. Well, part of it's under the Peace, Order, and Good Governance Clause, but there's also federal legislation that would allow them to do certain things as well. I don't know exactly what that would consist of or what it would be composed of. But there are certainly ways that it could be done. The other thing that I didn't touch upon, which is kind of related to your question, is that these powers are strictly divided, but a province and a federal government can agree to either suspend or compromise on these powers or share powers where, for example, in the past they may not have been shared, they could temporarily share them and that kind of thing. So in the context of a national emergency, it isn't just a matter of the government imposing its will, for example, through the Peace, Order, and Good Government Clause in Section 91, but it also could be them going to the provinces and saying, hey, rather than us imposing something, could we agree cooperatively to share this power or to let us temporarily have this power, meaning that the provinces, for example, would cede a power over to the federal government, probably not entirely, but maybe from a shared perspective, in order to achieve an outcome, and vice versa, potentially as well. So I think you're more likely to see something like that. And I think to the extent that that may be occurring in this country during the pandemic, it's clearly being done more on a shared, collaborative, cooperative way rather than anything being imposed upon, for example, the provinces or territories.
Thank you. Next question. Is there a central resource to help us understand the private insurance coverage options that are available to patients in Canada?
There may be, not that I'm aware of. There are, I believe it is 5 primary insurance companies in Canada. There are others as well, but there are, I think it's five big primary ones, like Manulife, Great West Life, that sort of thing. And each of them operates and provides those insurance services either through places of employment or through private insurance that you can purchase from any one of them. And I think you'd probably, depending on what aspect of insurance you're looking for, I think you'd have to sort of look at the individual sites and that sort of thing. There may be somewhere there may be some comparison, but the one thing that we always need to remember in the context of private insurance is that it isn't just a matter of, well, Great West Life offers this and Manulife offers this or whatever. These are very complex offerings, and they're offerings that are designed and developed largely for employers to offer to their employees. And even within those offerings, plans can be tailored and modified to suit an employer's needs, because the employer is the customer, and so largely the customer. Again, you can purchase it directly, but largely large employers are the primary customers in private insurance, and so those plans are designed to suit the needs of their customers, and it's somewhat complex in its nature. So I don't know of a central place you could go to find a comparison other than going and looking at each of the plans individually once you understand what component of the plan you're interested in understanding.
Wonderful. Next is, in what ways are publicly funded and privately funded, In what ways are publicly funded and privately funded healthcare collaborating in terms of delivery?
Privately funded. So say that again. Publicly funded. Did you say, Layla?
And
Sorry.
yes, so in what ways is private and public sort of collaborating in terms of how healthcare is delivered? Or is there any collaboration there?
Yeah, there is to some extent. So I think the question is, how do services that are provided through public funding potentially collaborate with services provided through private funding, if that's the question. There is some measure of collaboration. Collaboration might be a strong word. There's certainly some measure of information sharing and understanding of what the other one is doing. You certainly see it in medications is one example of where you see private insurers watching what's happening on the publicly funded medication side to a large extent, and also to a lesser extent today, the publicly funded drug plans watching what the private plans are doing in terms of prescription medications. But I'm not an expert on sort of how the two necessarily collaborate or communicate, or how they sort of interact with one another. There's of course the line between private insurance and public insurance, and depending on where you live in Canada, you may default to the private plan, depending on if you have private insurance. But if you do have private insurance, you might have to go to the private plan before the public plan. But if you don't have it, then you don't have the option of going into the private plan. Again, it's a bit messy, and it depends on again where you live, which province, and how as a patient, as an individual, which plan you kind of fall into, depending on, in large part, whether or not you even have private insurance. If you don't have private insurance, then you don't have private insurance. But I think it's fair to say, though, that if you live in this country and you have no private insurance, none whatsoever, you are going to have gaps in your care. You're going to have significant gaps in your care because only, as we see, only 70% of expenditures are done on the public side. So you've got a good number of services that require you to either have private insurance or to pay out of pocket. So anyone relying strictly on publicly funded healthcare, no private plan, no out of pocket, is going to have significant gaps in their care. No question about it.
Next question. What are some examples of countries that have a constitutional right to healthcare? And given the relatively few and minor amendments to the Canadian Constitution over time, do you see that changing at all in the future?
I don't know if any country has a right under, like, for example, a constitution or a charter. I don't know the answer to that question. In Canada, do I see it changing? Never. Absolutely never. And that is because of the amending formula that was adopted with the repatriation of the Constitution in 1982. This is a commentary. It is an amending formula with such a high threshold. It is so difficult to get an amendment to anything of substance, and that's clear because it's never been done in 37 years, 39 years, or whatever it is in this country. I do not see it happening, and I certainly do not see it happening in healthcare. I'm not saying it can't happen. I do not see it happening, and I do not see how the current amending formula would even allow for it to happen in practical terms. I can tell you the mechanics of how it could happen, but I can't see it in reality actually being able to happen.
Next question. You showed that Canada sits near the top of the list for per capita healthcare spending compared to countries around the world. Do most of the other countries with similar expenditures to Canada have similar private-public distributions of that spending?
That's a great question. I don't know the answer to that. Certainly the United States does not have a comparable split. I suspect that, and I'm guessing here, so my apologies if I'm wrong. I suspect that Germany and France would have a similar split. I don't know about Japan. I suspect Sweden might have a larger public mix, but again, I don't know. I do know the United States has a much smaller private, excuse me, public component in terms of the mix of public and private compared to pretty much the rest of the world. Certainly the rest of the countries on that list, I would hazard to guess.
Next question, if a person travels to another province, are they covered in that province for healthcare for the duration of their stay?
Yeah, you are covered by some services, but not all services. So you are covered you're covered through those services that are covered under the Canada Health Act. So if you travel to Alberta and you have to go to the hospital in Alberta can't say, oh, I see you're from New Brunswick, give me your credit card. They can't do that. But if you need something that's not covered or not deemed to be an insured service, then you will be charged. They are entitled to charge you, and you will be charged if you're in another province. So that's why for many Canadians, more and more, it's not just about getting out of country travel insurance. It's also about getting out of province travel insurance, even within Canada.
So I think we have time for one last question. Can the federal government include more criteria that province and territories must meet in order to continue to receive funding?
Sure, absolutely. They could amend the Canada Health Act. They could make it, they could do whatever they want under the Canada Health Act in terms of amending those 5 big buckets. They could redefine them. They could do, yes, they could absolutely do that if they chose to for those particular services, which would then impact the ability of, not the ability, the framework or the parameters under which the provinces would receive federal transfer payments for the delivery of healthcare. Yep, they could.
Right, so we're just about at 2 o'clock, so I think we'll wrap up the presentation for today. So thank you again, everybody, for attending, and thank you, Ryan, for such an excellent presentation. Our next webinar will be next week on February 25th, and it will be presented by Dr. Nicole Coulis-Reid and Julianne Dredger from the University of Calgary. Their webinar will be on their EXCEL program, which stands for Exercise for Cancer to Enhance Healthy Living. It is an exercise program designed for cancer survivors to promote healthier living, and information about that webinar will be provided to everybody as well. Thank you again, everybody, for attending, and take care.